professionals provide in this country. The social support is really key in this whole effort, and I can't emphasize that enough. It's been emphasized by a number of other speakers, but it's an integral part of how we provide care. These places are rugged places. They're not easy for patients to get back and forth from their homes to the health centers, and a lot of what we take for granted in this country for support doesn't exist unless you put it in place. And so we have these programs where there are trained accompagneurs who partner, if you will, with the individual patients, assure that they have adequate food, good drinking water, housing, and the other things. You can't treat a cancer patient if they don't have those things. It's not going to be a successful endeavor. And we go out to the houses frequently. Sometimes they're several hours walk. There are no roads in many of these locations to visit the patients, and this is one of the Partners in Health's group doing this, and I'm showing you this because on the left there is my son, who was in Malawi for a year working in one of these programs. I don't understand why he's the only one who's soaked in sweat and everybody else looks so fresh, but that's another story. But they go out there and they help, and it's really what makes things work for their programs. We developed a prioritization document and tried to figure out, with the very limited resources we have, because we have very limited resources in these sites, where do we want to spend our dollar? You know, I think that we've gone around about that some over the last couple of days, and this is going to vary site by site, but the three main sites that we've been working in, Haiti, Rwanda, and Malawi, are very poor sites, and we're very, very careful about using the resources we have where we think we can make the biggest impact on patients. And this is really not an all-inclusive type of list, but it's how we've thought about things. And I've constructed it, so I hope you can actually read it. But diseases curable with early detection and treatment, breast cancer and cervical cancer. Diseases curable with affordable chemotherapy, including lymphoma, testicular cancer, sarcoma in children, and acute lymphoblastic leukemia in children. Diseases that can be palliated, advanced breast cancer and Kaposi's, which is one of the most common cancers in Africa, and preventable diseases, including the tobacco-related diseases, cervical cancer, and hepatocellular cancer. Now, what's not on this list are many, many diseases we don't think we can impact on. And we're not going to treat actively with anti-cancer agents, though we are going to treat very, very aggressively with palliative care. Pancreatic cancer is not a disease we do very well with in Boston, and we're certainly not going to do very well in Rwanda with that, and there are many others as well, and we've been quite explicit about using our resources where we think we can have the greatest impact. Not everybody's happy with this approach, and I will tell you, we get a fair amount of criticism for not providing all the same care we provide in Dana-Farber and Malawi, but I would argue that that's not a possible thing. As part of this, we've developed specific disease-based programs, and these are very, very detailed standard operating procedures on how to take care of these patients, and they're critical if you don't have oncologists on the ground. You probably should have them even at cancer centers like Dana-Farber and for many things we do, but it's critical for them. And it's something they have there. They have it written down. They can refer to it. But in addition, though, as I will remind you, the Dana-Farber doctors are not far away. And when I was in Malawi visiting my son, making rounds, there was a 4-year-old with Kaposi's, literally asphyxiating from Kaposi's in the neck. We wanted to give him paclitaxel, and I'm an adult doctor. I don't know anything about dosing kids, no less a 4-year-old, and Taxol is not a drug we use a lot in pediatric oncology anyway. And I emailed my pediatric oncology colleagues at the Dana-Farber, and within 30 minutes I had all the dosing information, a couple of PDFs attached with pharmacokinetic papers on paclitaxel, and we treated the young child who did very well. Development of a supply chain for affordable drugs, vaccines, and other critical services. We've been doing this in sort of donation way from Dana-Farber, but that's not a long-term scalable solution to this. And so we've been working very, very hard at trying to construct ways to get a more reliable supply of the types of things that we need. Expansion of the partnerships, and I've really already talked to you about this, but we think it's key. We continue to try to work the best we can with the ministries of health and the governments, as well as with other groups like the Lance Armstrong Foundation, which has been very, very valuable in our work. And finally, this is one of the most important parts of this, and you've heard a lot about this, and I think we're going to talk about it a little bit after lunch, which is the development of a research agenda and infrastructure particularly designed to address the questions applicable to cancer care in these settings. And we are doing this from day one. We need the data. We need to know everything about demographics of the patients as it currently stands. We need to know exactly what we're doing to try to intervene in a better way with those patients. We need to be able to measure what the toxicities are of treatment and what the outcomes are for the patients. And then we need to take that experiment, if you will, this is like a laboratory experiment, and try to figure out what worked and what didn't work, and then plan your next intervention and remeasure and see if you're doing any better, and so on and so forth. It's got to be an iterative process, but it's got to be very, very well-founded, meticulous research right from the beginning. And I would say, and I believe this very strongly, that as a community, if we're not able to prove that we can make a difference in outcomes in these places in the world, it's going to be very hard to continue to garner global attention to cancer and funding on the long term. I don't think they're going to take our word for it for the next 10 years that we're doing a good job and we're making a difference. I think we have to prove that we're making a difference. So, from the breast cancer point of view, how do we have the greatest impact in breast cancer with limited resources? Develop educational components and care packages to reduce the stigma among women and reduce the obstacle to benefit the greatest possible number of women within a solid healthcare infrastructure. We've heard a lot about that. I'm not going to go into the details of this. What's the basic package of detection, diagnostics such as pathology, ER testing, HER2 testing, surgical services that we need for effective treatment? What's the basic package for systemic therapy that we want to try to put in these sites, and then the social services, as I mentioned. This is the essential package that we've come up with for our sites. Obviously, awareness and education through community-based campaigns is key. We have a hook into the population. They participate actively in healthcare in these sites, and they need to be educated, examined, and so on. For screening, we use breast self-exam and clinical breast exam, and we've been training community health workers to do good clinical breast exams. It's a whole other story about how we're doing that, but you'll notice that mammography is not part of this currently at any one of these 3 sites. Diagnosis, we're really focusing on ultrasound-guided cord needle biopsies. And we're using turkey breasts and olives and not chicken breasts and olives, but we're training a team currently that's going to be going over to Rwanda to try to scale up this program in the next couple of weeks. We're trying to figure out some of the pathology, and we're making some progress there, and surgery